done her master in neurometabolism and cell biology at Barcelona University, Spain. So she is running genetic clinic at Chhatrapati Sambhaji Nagar, and her area of interest is like lysosomal storage diseases and inborn errors of metabolism, dysmorphology, and she has 35 publications in her name, and she has also published a book on FAQs in genetics. So with this, I would like to invite both the speaker and the mentor, and with the sir's permission, we can start with the activity.
Dr. Neil, should we
So,
start?
Doctor.
Yes, sir. Yes, sir. The platform is all yours, sir. You and all the pages with all of us learning.
Yes. Good evening, friends. Welcome to this our Tuesday PG clinic. I acknowledge the presence of all the office bearers and dignitaries, and I request particularly the student that please remain on the screen with your video on and participate in the discussion without any hesitation. Whatever comes to your mind, and we have I will say the experts like Dr. Suvarna. She has, I will say, specialization in the genetic and metabolic disorders. So I'm sure that something we are stuck up, she'll be able to help us. With this remark, I request Dr. Karthik, today's presenter, to share his PPT to make it full screen and start the history part. Dr. Karthik, please.
Yes.
Karthik, are you able to make it full screen? Yeah, fine. Good. Please go ahead.
Good evening, one and all. Thank you for your warm greetings. And thank you, respected Central IAP team and Dr. Trupti Joshi ma'am for giving me this opportunity. So should we start, sir?
Yes, yes.
Patient named Master Mohammad Saad Akbar Sheikh, a 11-year-old 6-month male child, 5th order by birth, born out of 3rd-degree consanguineous marriage. The informant being the mother, who is reliable. Previously developmentally normal, came with complaints of behavioral changes since 1 month, difficulty in walking and sitting since 15 days, decreased scholastic performance since 15 days, loss of bowel and bladder control since 15 days, and difficulty in speech since 15 days. The history of present illness: an apparently well, scholastically normal 11-year-old boy presented with complaints of behavioral changes since 1 month in the form of forgetfulness, incoherent speech, and abnormal smiling and reduced memory, which was sudden on onset and was progressive. He also had difficulty in walking in the form of loss of balance since 15 days, which initially was intermittent, which gradually progressed over the next few days to inability to walk independently and difficulty in maintaining sitting posture. There was progressive worsening with the child becoming dependent for mobility. Loss of bowel and bladder control since 15 days. It was more during the night and less during the morning time initially, but later it progressed and the child had it during the daytime too. Parents also noticed difficulty in speech since 15 days, characterized by slow, reduced verbal output and unclear words, which progressively worsened over the illness course. During the hospital stay on day 3 after admission, the child had complaints of multiple jerks of upper and lower limbs around 10 to 20 times in a day, each lasting for a period of 1 to 3 seconds, and it was not present during sleep, and child had received some IV medication for this. Child also had decreased vision in the left eye since day 3 of admission, which was sudden on onset and progressive.
Okay,
There was no...
can you stop sharing for a while?
Yes, sir.
Before you go further for this information. Yeah, thank you. I think first let me identify the students. Karthik, your colleagues must be there. We can take their help in the discussion. Karthik, can you name some of them or those who are on the screen? Don't hesitate. They will not scold you. Is there anybody? Karthik, your colleague? Because why I want to go to them, you may be knowing the details of the case. Then probably it may be little bit biased discussion or information. The person like me, that not knowing anything, that will be good. Yes, Madam has put some names, Dr. Yashwant, Ansir and Supriya. Number one, my request to all the students that please don't feel any hesitation. And here, it is not the exam. Whatever I will see your understanding, interpretation, you can respond. Not necessarily always it is right. Even many a times what we say, later on we realize that what we understood was not right. So it happens so in the medicine. So I think with that, just a word of encouragement. Dr. Supriya, can you come on? Dr. Supriya, can you make your even video on if you don't mind?
Hello, yes, sir, just a minute.
Yeah, okay. No problem. I think just your voice is reaching, that's good. What I want to know very nicely, Dr. Karthik has described these complaints of the child.
Yes, sir.
I'm sure that Dr. Srinivasan sir will say 11 and a half years old, male, if you say the child, they don't like. So
Yes,
better to call them the adolescent or something like that. Because
Yes,
if
sir.
you say the child 12 years old, they don't like. And that's
Yes, sir.
certainly right.
Nowadays, even a 5-year-old child doesn't want to be called child.
Yes, sir. So 5 years old child, even they don't like that if you call them the child. Absolutely. And now here the complaint, already you know that started with some behavior problem, difficulty in walking or so. Can you take one by one? I will say what behavior, Karthik, can you just repeat without sharing that what problems were observed regarding the behavior?
Yes, sir. He had since 1 month there were complaints of forgetfulness, sir, and
Okay.
there was incoherent speech,
Right.
and he also had abnormal smiling, sir, and there
Yeah.
was reduced recent memory.
Very good. So, Supriya, what will be your interpretation? What does it indicate from this behavioral or these observations of the parents? That something is wrong with the smile naturally, it's not right. Child is having, I will say, forgetfulness, some problem of the speech they noted. All these disturbances, what does it indicate? Just I want to give the idea, always try to think the anatomy.
Yes, sir.
Whatever the
Sir,
condition, but 1 minute, please. First, which part of the particular system or where is the problem? And second thing, then we will think that what problem, what pathology or disease can behave in this way. Can you focus on the behavioral problems? What does it indicate? Supriya.
sir, the problems of forgetfulness, speech difficulties, and abnormal smiling indicate that probably there might be something wrong in the cortex of the brain.
Absolutely, very good. I think this is the thing which I wish. As the parents start or the patient complains, our thought should start that where is the problem? What does it indicate? Where is the involvement? So I think very nicely she said, all of us know that these are the functions of the cortex, memory, speech, right? And if these things are affected, even he has later on mentioned the school performance is also affected. So certainly it indicates that the cortex is involved. Okay, number one. Second, I think another person, Dr. Yashwant, can you come on? What another complaint Dr. Karthi has mentioned that difficulty in sitting and walking. What does it indicate? We
Sir,
hope that already has made the point clear that before this illness, the child must be, I would say, normal. Am I right, Dr. Karthi?
Yes, sir.
Yeah, whatever the illness he has mentioned, 1 month, 15 days, like that, the story started. So difficulty in sitting and walking, what does it indicate?
sir, one thing is some gait incoordination might be due to white matter involvement and cortical tracts were
Right.
affected.
We know that there can be several reasons with the problem of sitting and walking, but already your colleague Supriya has started that the problem started with the cortical involvement. Later on, this problem, that means we understand that something is wrong with the locomotion. Let us keep in this way, that locomotion. Now, locomotion also, suppose if we think for the neurological, there are several reasons for this locomotion, maybe some rheumatological condition, maybe sometime due to some pain, sometimes even the involuntary movement, incoordination, several reasons can be there. But I think here already we have coined, focus that it's a neurocystic problem, then we will naturally consider that this problem also, difficulty or complaint, is also likely correlated to that. And then which part is affected? Yashwant, can you just again repeat it?
Sir, white matter it affected and tracks were affected.
Yeah. At least we can say that yes, it can be due to one peripheral problem also. So spinocerebellar or anywhere. Or even, yes, because already central problem, so maybe the related to that and now extended to the white matter or we know that white matter is playing a major role in the coordination and walking and all this. That maybe even with the white matters, even with this basal ganglia involvement, even with the cerebellar involvement, all this even of course and the cortical distracts are there. So we I will say try to understand that something is wrong with this at least the locomotion. And therefore, any of these or the multiple components might have been involved. Third problem further. Loss of bladder and bowel. Again, Yashwant, can you take it? What does it indicate? Dr. Yashwant or Supriya? Karthik, can you make the comment that now the involvement of bladder and bowel? I think you can just describe it that in what way it is affected, bladder and bowel?
Sir, if there's cortical involvement, mostly maybe
No, Karthik. I want the details. You know, the people want to know the details. Then in what way bladder and bowel involvement?
loss of bowel and bladder control since 15 days, sir.
Okay,
Which
that means unnoticed child is passing urine or stool.
yes, sir.
Yeah, and really there is a soiling of the clothes.
Yes, sir. There was soiling of clothes, and it was more during the night, sir, during sleep time.
Okay. So what does it indicate now, Dr. Karthik?
The cortical involvement, sir, suprapontine.
So I know I will say peripheral because you know it can be even due to the involvement of the spinal cord also, right?
Yes, sir.
But again, as you said, both the things are possible. But already it has been started with the speech, memory, the higher centers. So likely we may consider the first possibility that involvement of this, even again, the control centers of these organs. Of course, even spinal cord is also remains one of the possibility for the involvement. Then difficulty in speech, again, already made the point clear. And now, as a whole, Karthik, if you want to interpret all the problems together, what will be your, I will say, comment that what does it indicate? What type of the disorder? What problems are, I will say, going on to the child? Further, I think you mentioned some jerks also. Sorry, I missed it.
Yes, sir.
What are the details of the jerks?
After day 3 of admission, sir, there were multiple jerks of upper and lower limb, around 10 to 20 times per day, each lasting for 1 to 3 seconds, sir.
I think I will remind all the students that when you are describing complaints and origin, duration, progress, as far as possible, it should be the language of the patient or the parents, informant. But we may not interpret because what they describe is very important, right? What you say, jerk even, I may interpret something else. I may say it's syncope. I may say it's seizure. I may be even to interpret something. So what they describe, that is better to go for the narration of their story. Okay. And further, you say decreased vision. In what way? Again, vision parents noted or the
Yes, sir.
child complain of?
The child had complained saying he's not able to see distantly since 3 days, sir, after admission.
Was it gradual or suddenly? That suppose
Suddenly.
initial difficulty in vision, then I will say decreased vision, and then now not able to see at all. Was it like that, or suddenly child complain of decreased vision or loss of vision?
Suddenly the child had complained of decreased vision, sir.
Okay,
Decreased.
then how it is possible?
Uh,
What will be your, I will say, way of interpretation regarding the vision?
it-
Suddenly
the,
what
the form,
happened? What I mean to say, suddenly what happened? Where happened? That it resulted in the problem of the vision. And suddenly, as you said,
yes, sir. If optic nerve is involved, then it could lead to
an
decreased.
optical involvement in what way? Because so sudden, really, if you have interpreted very appropriately,
So anything which might have caused a raised intracranial pressure might account
okay,
for the sudden diminution of vision.
okay. Dr. Anju, very good.
Yes,
Fine. Anybody else? Now, Dr. Anju, I hope that you were there from the beginning.
yes, sir.
Okay, so can you try to put all the problems or complaints together? Already we have analyzed each complaint.
Yes,
That
sir.
here 11 and a half, almost 12 years old male boy is there, and he has this problem of about 1.5 to 2 months, Dr. Karthik.
Yes, 1 month, sir.
About 1 month, started with some behavior changes, then difficulty in walking, bladder and bowel involvement, speech, some jerky movements, and the difficulty in vision. If you put all the symptoms together, what will be your interpretation? How you are taking it? What does it indicate?
So I feel the primary pathology will be from the cortex only because the behavioral change might be due to the frontal lobe involvement.
Okay.
When you put all these together, the memory.
Why you are considering the frontal lobe involvement? What points are suggesting involvement of frontal lobe?
So the behavior
Behavior
usually,
problem, okay.
and secondly, the memory. I'm not concluding everything to be from the frontal lobe because
Yeah,
memory can be from the temporal lobe and
yeah,
bladder and bowel inhibition primarily comes from the frontal lobe.
absolutely. Very good.
Uh,
So what does
so
it, I think what you can make the statement
So
that
might be from the information we have till now, it can be a space occupying lesion or something which might have caused to the raised intracranial pressure, which might account for the acute diminution of vision after the child was admitted to hospital.
okay, where is the space occupying lesion? Which part of the brain? I
Uh,
think you must be knowing that commonly how the space occupying lesions present. Mainly they present with the signs of raised intracranial pressure first.
so,
Then probably areas from where it is originating, pressure effect or something, and then the accordingly vision will be there. Here it is I will say widespread manifestations are there. Because as you said, the bladder and bowel involvement, memory is affected, speech is affected, school performance is affected. So many, I will say, even jerks are affected. So what you can make out that widespread cortical lesion, it should be the diffuse, it should be diffuse. Rather than making it well localized, it is a diffuse. It is a widespread. And from this, you can say cortical lesion. Okay, good. What else, Dr. Anju? Can you take it further, Anju? What else? How will you explain this? Already we have discussed this locomotion and other things.
so due to the we are suspecting a widespread or diffuse cortical lesion
Right.
because of which multiple part of the brain have been affected. Because of which maybe the more than periphery it is a central cause only. So maybe the cerebellum might be accounting for the gait disturbances.
Very good. Okay. Commonly, suppose cerebellum is involvement, what type of the manifestation of the locomotion is there? What is the common manifestation? Any cerebellar problem, sort of cerebellitis, or some space occupying lesion of cerebellum like astrocytoma, medulloblastoma, right? Or something
There
Exactly.
will
like
be
that. How commonly they, suppose if it is manifesting with this locomotion, then what will be the complaint?
there will be a
Ataxic
gait
gait.
ataxia. Child won't be
Yeah,
able
mainly
to walk
ataxia,
properly.
right? Mainly ataxia. Somehow here it is not a very specific ataxia. And therefore, I will say what already we have interpreted that likely some white matter involvement. Even it does not indicate the basal ganglia involvement also, because that will be also the very characteristic problem of the gait will be there. Having this, I think we can take in this way. Anyway, suppose if we take, okay, that it is the anatomy point of view, we decide that it is generalized, diffuse, widespread,
Right.
slowly progressive cortical lesion. Okay, that is anatomy. Now, can you make the comment on the pathology? That what type of the pathology it is? Again, Shruti. Shruti, can you take this point? She was there, I think she's there or not. Another person was Dr. Ansi.
Sir, could this be due to demyelination in
Yes.
the cortex?
Why? Supriya, how we are able to interpret it, demyelination?
Sir, because since it is diffusely
Demyelination is the characteristic of? Demyelination is characteristic of which structure? What I mean to say, which structure of the CNS is having the demyelination?
Neuron.
so axon.
It is specifically the white matter.
Right.
You know that white matter structure, it is myelinated. Now
Yes,
it
sir.
is a demyelination, that is, but the speech or even this memory, even suppose if we consider central lesions for bladder and bowel, then which structure is specifically involved? Now we go for the not anatomy, we go for the microanatomy. Right? If I remind you, you can think in this way. The cortex, how it can be involved? It can be the gray matter, it can be the white matter, it can be vascular, right? It can be space occupying, right? It can be infective, something like that. So from this point of view, what you can consider?
So gray matter involvement seems more
Yeah,
likely.
because memory, school performance,
Memory.
speech, these are the higher functions, and we know, and even the jerks. Again, that is the one variety if we consider of the type of the epilepsy, suppose. Then it indicates that this is a gray matter involvement, right? But at the
Yes, sir.
same time, difficulty in walking and bladder, we are not sure, even maybe the spinal cord or somewhere, even the long tracts or the white matter can also be involved, right? Okay, but which type of the pathology? It is congenital? Is it traumatic? Is it vascular? It is space occupying? Is it infective? It is a degenerative? It is a autoimmune? It is, I will say, in the form of, there are what varieties of pathology. And every pathology has a characteristic. From this characteristic, what will be your interpretation? Supriya, can you take it? You are, I would say, mentioning very nice points. Can you take it? Among all these various regions, which one you are suspecting in our patient?
Sir, in this case, I feel it is more likely to be degenerative or autoimmune.
Why?
Sir, it can't be
Another
congenital.
thing always in our medicine, we'll have to give you the probable explanation. Yes, Priya, Supriya, take it.
Yes, sir, since it was sudden in onset and it presented later in life, around 11 to 12 years of age.
Okay.
So it is unlikely to be congenital. Then there is no history of any fever episode preceding this. So
Very good.
infective causes
Very
are
good.
also ruled out.
Yes.
And causes of raised ICT are also not so apparent in this course. So space occupying lesion is also less
Fantastic,
likely.
fantastic. Yes, further.
Then, so vascular causes vascular can be one of the causes in which there is a sudden infarct or embolus somewhere,
Right.
which can present in this way. And so vascular or degenerative or autoimmune can be there.
Very good. Supriya, you are at present in which year?
So fine, third year.
Okay, fine. I think you are preparing for your final examination. Good. This should be the reasoning. Then how we can. She said already congenital most of the times, may not be always, but most of the times we are expecting that it may present early. Here it is almost 12 years. So less likely. We can make the comment in this way. Traumatic, usually following some trauma, suddenly it develops. Many times it is hyperacute. Right. Vascular is different. It is thromboembolic, embolism, hemorrhage. It develops suddenly, that the maximum damage, remains static for some time, then goes for the recovery. That is a very classical story, which is somehow not indicating. Very nicely, Supriya mentioned that absence of fever probably does not indicate the presence of infection. Of course, another reason. She said even this space occupying lesion usually starts with the raised pressure, gradually progressive. That of the story is not there. But very nicely she made the comment that here whatever the functions already he had, within a month period, various functions of the brain are affected. And child is gradually losing even to that extent, the bladder and bowel control is lost. Even the speech disturbances started, memory disturbances are there, and even the sudden loss of vision is there. That means whatever the already functions were well, child is gradually losing. And therefore we can say that likely some degenerative process. Very good. And of course, autoimmune, other differential diagnosis, we'll have to keep it. I will say very nicely you have discussed, all of you, Supriya. I will encourage, even Dr. Anju was there, Yashwant started, and I wish that please remain in this discussion with your further thoughts, and we'll be able to understand it, that how really the story is there. Anyway, I think before we go further, any teacher having some comment or to add something, or even I will say, Madam Suvarna is there. She must be knowing the case, but still, suppose being her speciality, something is suppose she wants to add, please.
Sir, I mean, you carried the case presentation and involvement all the students so nicely. Like even I'm learning from this discussion and whatever discussion is happening here. So very rightly, the discussion is on the very correct track, and I must think that the students are enlightened with this much portion also, like just with the chief complaints and the discussion. It's amazing.
Thank you, madam. Srinivasan sir, anything from your, because always your presence is there and you are most senior, I will say, on the screen. Sir, you are muted. Please unmute yourself. Sir, unmute yourself. Srinivasan sir, you are muted.
Yeah, I was just listening, telling that yeah, I'm one of your constant students and I am learning so much every time.
Sir.
And the systematic analysis of each and every symptom. Yeah. So that's why I don't want to miss this opportunity.
Very nice. So, sir, that is your modesty that you are, but you, all of us know that you are inspirational person for all of us. Anyway, I think let us take the further. Karthik, you can share your PPT and take the story further.
Yes. There was no history of pain or swelling in the limbs, upper and lower limbs. No history of any involuntary movements. No history of weakness in upper
Karthik, can you make it full screen?
Yeah, make it full screen. It's very
Yeah.
small letters.
So that even everybody can read it. you know, the icon at the bottom.
There was no history of pain or swelling in the upper and lower limbs.
Yes, yes, now
No
it is full
history of
screen.
any
Very good.
involuntary movements. No history of weakness in the upper and lower limbs. No history of nystagmus, intentional of tingling sensation or numbness. There was no history of any rash, ear discharge, or sinus infection. No vomiting, headache, or early morning worsening. No history of postural dizziness, sweating abnormalities. No history of abnormal pigmentation of skin, any skin or hair changes, fatigue, and recurrent vomiting. No history of any dog bite or hydrophobia. No history of recent vaccination. And there was no history of any strict vegetarian diet. No history of abnormal odor of urine.
Okay, I think before you go further, again, please stop sharing because you have mentioned some important points that we would like to take it. You can stop sharing, yes. I have taken this photograph so that I cannot forget the negative points. Again, please, all the students, that what negative point Dr. Karthik has mentioned, what is its importance in our case that you can justify? No history of pain or swelling in the limbs. Supriya, why he has mentioned? How it is relevant in our patient? Dr. Supriya?
Sir,
No history of pain or
pain,
swelling in the limbs.
Trauma.
Yes,
history of
Ashwan, very good. I will say multiple people should start to speak. That is the good. I think both can speak one by one. First, Yashwant, what is your comment?
Sir, the patient is having no pain or swelling due to trauma or some musculoskeletal pathology, and nerve root compression can cause. There is no pain. Matlab, there is no nerve root compression or any spinal trauma.
But he has mentioned pain or swelling in the limbs. He has not mentioned at the back.
Any thrombus in the limbs?
Okay. Let us ask Karthik what was in his mind. Karthik, what are your point regarding this no history of pain and swelling in the limbs?
To exclude any causes of pseudoparalysis, sir.
Okay.
Like due to pain if the child is not moving his limbs.
Do you expect that then what will be the chief complaint of the patient? This is a good point even, I will say.
Like
always this is very important, the medicine. That what was the chief for what the child is brought to you. Suppose the child is not able to move the limbs due to the pain, what will be the chief complaint of the patient?
Difficulty in walking.
I will say pain rather than walking. And that's why always what we discuss in the medicine, that find out what is the chief complaint, that will guide me further. Then if the child is not walking, and if I ask the question to the patient, in the pain, what happens? Child is trying to walk, but not able to walk due to the pain. That will be the story.
Claudication pain, sir.
While in a neurological case, what happens? That there is the loss of that function. Pain is not there. That becomes very distinctly clear. And therefore, always in this type of the presentation or problem, make the point clear that not able to walk due to what? Is it here due to the pain? Then the story will be different. And really, pain is not there. Still having some difficulty in walking or not able to walk, that leads to some neurological condition. Right? So that's why I asked the questions to you, that is it relevant to our patient? Probably no, because there is no question of trauma, there is no question of pain. Anyway, no history of involuntary movement.
To rule out.
Yeah, Dr. Ansi?
There is an involuntary movement. Patient had jerks.
Yeah. Very good, very good. Both of them is Ashwan. No, we can't make the statement that there is no involuntary movement. At least these movements, what you later on verify that is it really some specific movement problem or really jerk or even the seizure or something is a different story. Anyway, weakness in upper or lower limbs. Yashwant, how will you interpret it?
Pyramidal tract involvement, pyramidal tract.
No, he has mentioned no history of weakness in upper or lower limbs. Do you agree with him? There is no weakness?
There is no difficulty in walking.
He's not able to walk.
So there is weakness. Weakness is present.
Yeah. At least not able to walk. Nystagmus okay. Intention tremor okay. And what you want to mention? I will say clarify regarding the intention tremor. Karthik, what is the idea?
Intentional tremors, if to rule out any Parkinsonism.
Okay. And tingling numbness. Whether the child was in the status of the answer you or very precisely respond you, whether there is no tingling and numbness?
Yes, sir, he could.
Okay,
he was
fine.
Really able.
And suppose if it is there, what does it indicate?
Sensory ataxia.
Okay. Usually this tingling and numbness peripherally, that means neuropathy, peripheral neuropathy, right? Anyway.
B12. Vitamin B12 deficiency.
B12 deficiency.
Yeah, anyway, good. Another thing what I want your attention to all the students, that negative points should be decided by you, which are relevant to your patient's problem. At some point, presence or absence helps you, whether it's strengthening your possibility or excluding your possibility. Or another help you will take by mentioning the point which decides for differential diagnosis. And third aspect, a specific complication which is expected in your case, whether that complication is present or absent. So having relevance, I will say relevancy of these points, you should find out the negative points, not all which is given in the standard textbooks. Anyway, I think Karthik, you can take this point to save the time. No rash, ear discharge, sinus infection, what you want to convey?
To rule out any CNS cause, sir, like rash, it could be some viral encephalitis or any measles complication. And
that's why I said, how that patient will present. That patient will not start with the, I will say, problems in this way, right? They will start usually that with a rash or even the altered sensorium, seizure, something like that. Anyway, no problem. Headache, early morning, I think you want to rule out the regional pressure, okay. Okay. Postural dizziness, sweating.
Any autonomic dysfunction, sir, if present.
Okay. Abnormal pigmentation of skin.
To rule out any metabolic or endocrine disorders, sir.
Right, particularly even the neurocutaneous disorders. Dog bite, very important here. And that dog bite may be so in the past that even the person might have forgotten, even the family members must have forgotten. But history of dog bite and this type of CNS presentation, one of the possibility remains even the rabies, and therefore it is really relevant. Same hydrophobia, recent vaccination, yes. Some vaccine can also post-vaccine CNS problems.
Post-infective.
Can you give an example that which vaccine can go for the adverse events in the form of the CNS involvement in this way?
Pertussis.
Pertussis usually, encephalopathy will be different. Again, the age will be different, right? Because pertussis will give the initial 3 doses and 1.5 and second. So probably, but any other vaccine?
Measles.
Okay. Okay, measles can do it, right? Even nowadays we don't
rabies vaccine.
Yeah, nowadays we don't use comparatively this modern rabies vaccines are safe, but in the past, equine preparation which we are using were very dangerous. And B12, yes, very important. No history of abnormal odor of the urine. Yes, Karthik, what you want to specify?
To rule out any inborn errors of metabolism, sir, such
Like,
as
can you
phenylketonuria.
give some examples with the very specific odor of the urine suggesting some metabolic disorder? Give some examples.
Phenylketonuria, sir.
Right? What type of the odor will be there?
Phenylketonuria has
mousy order.
Okay.
Ma-
then
Yashwant, can you give some
maple,
examples?
yeah,
Some,
tyrosinemia is cabbage-like order.
yeah, styrosina cabbage like that.
maple syrup
What
has
happens in maple syrup urine disease?
burnt sugar.
Yeah,
Burnt
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 sugar.
sugar.
I will give one more, even the suggestion to the students. Suppose in the exam, if you don't know immediately, better not to mention this point. If you are knowing, positively mention. So that examiner will ask you and you will be having a good performance. But suppose by chance, if you don't know, don't invite the trouble. Because you mention and then certainly there will be the question. So I think this is another thing in the exam. Before mentioning, you should be aware. And suppose if you are knowing, positively mention so that examiner will ask the question. And if you are able to answer, it will be the good performance. Anyway, good, I will say negative points also mentioned. Karthik, your presentation is really good. Now can you take it the story further?
Yes, sir.
And you can complete the history.
Past history and family history. There were no similar complaints in the past. The child had a history of measles and jaundice at 18 months of age, and there's a history of head trauma 20 days back.
Karthik, you said no similar complaint in the past.
Yes, sir.
Can you give an example where such type of a neurological problem develops, patient recovers, and or even the partial recovers, and again the manifestation develops. So that type of the story, as you said, no complaint in the past. But suppose some child is having the complaint. Can you give some example? Again, that's why I say in the exam, if you are not knowing, better not to mention. Because certainly the question is going to be there. Srinivasan sir, yes, sir wants to say something.
Can I make a remark?
Yes, sir,
Yeah.
please.
Regarding the pedigree chart, especially when you are having a case like this, you must have at least 2 generations.
Yeah.
Here there is only one generation. That
Yes,
way we cannot pick up genetics.
Absolutely, absolutely. What sir said, on the contrary, 3 generations, and in the presence of, I will say, genetic specialist, madam, she will guide us that how we should prepare this pedigree. This is very important. Nowadays, you know that many conditions were available. So some people even, you know, from this, just to prepare the pedigree, and probably there may be the involvement of the various disorders will be obvious.
Yes,
So,
sir. Totally agree, sir.
yeah. So
Three
please,
generations.
as sir guided, Srinivasan sir, that better to go for the pedigree, at least minimum 3 generations in this type of the disorder. Okay, I think all the students should take note of it. Very good. Anyway, but yes, Karthik, somebody put the answer. When I asked that which disorder can you give the example, where even waxing or waning or recurrent problems will be there. Multiple sclerosis like disorders, they can having this type of the story. Even some autoimmune disorders, yes, they can have this type of story. So here, you know, because you mentioned in the exam in the history, some examiner is going to ask the question, and you should be prepared that this question is expected, right? And if you are prepared, I'm sure that your performance is going to be the good, right? History of measles and jaundice at 18 months of age together, jaundice and measles together.
First he had measles, sir, then jaundice.
Means at what interval?
Interval
You know,
of
why I am interested whether the measles was responsible for the jaundice. what is your I will say interpretation? What is your point regarding measles and jaundice at 18 months?
Measles could lead to like complication of measles can lead to such a presentation. Sir. This
Which presentation?
SSP, subacute
No,
splenic.
I don't know whether in this patient SSP or anything. I'm interested to know measles and jaundice at 18 months. Whether measles can cause the jaundice, whether they were together, or was there some interval? They were the two different illnesses. What is your interpretation?
They were like mother had given history that they were together, so around 18 months of age.
Karthik, naturally, mother does not know the importance to consider together or different or separate. Right? As a clinician, we'll have to find out. On the contrary, she will say she will even club all the illnesses together, which probably may not be relevant to us. So my point, I think that we should try to find out. Anyway, but I think measles and jaundice together is less likely, less possible. Reason is, measles usually does not cause the jaundice. Yes, measles can cause the pneumonia. Yes, measles can cause the vitamin A deficiency. Measles can cause the encephalitis. Measles can cause the flare-up of the tuberculosis. Measles can cause the dysentery. Right?
Yes, sir.
But usually measles involving the liver and that in the form of the jaundice is less possible. And really it was the story. We should go in the details. Right? This is just to point out. Okay. Head trauma 20 days back. Karthik, you said no history of trauma, and now we are mentioning head trauma. Then again, we have to go in the details. What type of the head trauma? Because 12 years old boy, I am not expecting just head trauma. While I would say playing or walking also, unless it was really significant impact. So clarified.
Not significant impact, sir. He was climbing a ladder, then he had fallen down. Then he had sustained an injury to the head, backside of the head. But there was no loss of consciousness, no vomiting, no visual disturbance post that, sir.
The question is going to come, is it having relevance with this 20 days back head trauma?
Likely no relevance, sir. 20 days.
I will take in some other way. Whether head trauma manifested with this illness or this illness was responsible for the head trauma. What will be your stand? Yashwant, how you will take? Let me ask others. Yashwant, did you follow my question?
Once, can you repeat, sir?
Yeah. What he has mentioned, history of head trauma 20 days back. Now, how you want to interpret?
No, the history starts.
Let me make the point clear. Really, the head trauma resulted in this illness? Or really this illness having some, I would say, link with the head trauma? What is your interpretation?
Sir, this illness is having link with trauma because the history starts since 1 month.
Yeah, then?
Since 1 month, he is having behavioral changes. So the course continues. So it's not the trauma leading the symptoms.
Very classically, you know what Karthik has mentioned, that illness 1 month, difficulty in walking and sitting since 15 to 20 days. So probably with these disturbances of gait, he must have lost his balance, probably must have the impact over the head. So rather than the head trauma, I will say it was a part of this illness. You know, in the clinical medicine, this is very important that how we are interpreting. Many times what happens, we used to get the patients in the past that already tuberculoma was there. Following fall or something, some impact, the tuberculoma will manifest in the form of the TBM. So that fall didn't create the problem of the TBM. But the whole problem was due to the difficult, that illness. So better to how you are, I will say, correlating, how you are establishing the, I will say, link between these two episodes or events. That is very important. I mean, it's a very good point. I want to clarify these points for the students, that how you are able to, I will say, establish the link between these type of the events. That is very important in clinical medicine. Good. Yes, Karthik, take it further.
Yes, sir. Family history, no history of similar illness, seizures, developmental delay, a sudden death in the family members.
Very good. I think this is very important. Not only even in this particular child in the past, but you should serve, and therefore pedigree is very important.
Yes.
3 generations. That any member in the 3 generations was having any type of the illness in the form of the seizures, developmental problem, sudden death, something like that. Good, good. I think you have taken the history very rightly. Please go further.
Birth history, antenatal history, one scan was done at 5 months of gestation. The mother had taken supplements. The child was born out of vaginal delivery, which was a home delivery. Full term, cried immediately after birth with a birth weight of 3.5 kgs. Postnatal history, there was no history of any NICU or PICU admissions. Immunization and developmental history, the child is immunized till 10 years of age. Developmentally, the child goes to school and studies in 6th class, was good in studies and mingled with friends prior to the illness. Dietary and socioeconomic history, the boy consumes 1,883 kilocalories of expected 2,190 kilocalories with a deficit of 307 kilocalories. And he consumes proteins of 33.7 grams of expected 39.3 grams with a deficit of 5.6 grams. Socioeconomic history, the father studied till 8th standard, is a construction worker. Mother studied till 5th standard and is a homemaker. The family income is rupees 10,000, and according to modified Kupuswamy scale, the family belongs to upper lower class. The family lives in a pakka house, uses LPG for cooking, has separate toilet facility, and there's no open air defecation. The nearest health facility is within 1 kilometer.
Good. Even these details are also very good you have mentioned. Please go ahead.
Summary, 11.5-year-old male born out of third degree consanguineous marriage and previously developmentally normal, presented with progressive behavioral changes for 1 month, including forgetfulness, incoherent speech, and reduced memory. Over the past 15 days, he developed progressive difficulty in walking and sitting, along with loss of bowel and bladder control. There was associated decline in the scholastic performance and progressive speech impairment. For the last 3 days, he started to have multiple brief myoclonic jerks and sudden onset decreased vision in the left eye. And there is a past history of measles infection at 18 months with no significant family history. So my probable diagnosis would be SSP in the first. Second, it could be any gray matter disease, a white matter disease, any autoimmune condition, or Wilson's.
Okay. Now can you stop sharing?
Yes.
I think good history. First, let me appreciate Karthik for giving the really good details of the history. Now, other students, you know that after the history, already probably you have taken about an hour in the history. And that is very important. The CNS particularly, I will say in any system, it is said that in the history, 80% diagnosis is revealed. Rest of, I will say, you can expect even the findings on examination. Investigations are just for the confirmation. So I think very good point. I think before we go further, Srinivasan sir has some comment. Sir, please.
No, because I have found, during the DNB exam,
Yeah.
they'll say modified Kupuswamy scale. Then immediately the examiner will ask, what is the latest this thing? What is the latest year it has been, the new modified. That's a
So
common question which is asked
common question.
immediately.
Yes, you should be prepared. Absolutely. In the exam, I think simultaneously in the discussion, all the teachers are guiding you for the exam also. That besides, I will say preparations, reading, how much to speak, how to prepare the presentation, which even point you should speak. You should take even some pause. Suppose if you are knowing, if you are not knowing, don't take even mention that point. If you have mentioned, smartly try to answer. These things are also very important, I will say, part of presentation. Anyway, I think
latest is the last year 2025. So they must know, because they get trapped and then they feel bad that they haven't been able to answer correctly, and then their
Absolutely.
performance becomes bad after that.
So all the students are requested that please go through this very simple question, but somebody is going to ask me modified Kuppuswamy, and then you should know that when it was last or latest modification was done. Anyway, I think now the summary, now what I want, Karthik, from other students. Summary should not be the repetition of the same story which already we have discussed. Your interpretation from this discussion, your, I will say, analysis from this discussion, your hypothesis, that what you are considering, what is the likely problem with the child. And for that reason, in the neurology, Dr. Brajesh Udari several times, I will say, mentions that use the multiple adjectives. That suppose the disease, try to define, is it acute, subacute, chronic? That will give you some ideas. Second thing, after that, you can even mention that what is this, what type of the disorder it is. Try to find out the anatomy. Then mention even the progress of the disease, whether it is static. In neurology, some diseases are static. If it is progressive, in what way it is progressive? It is slowly progressive, or it is rapidly progressive? And then what is the present function of the organ? Present function of the organ. That will give you, I will say, some picture that what type of the disorder it is. And then consider the various possibilities. I think Dr. Dilip, somebody is there. Can you mute yourself, please? So that is our idea of preparing the summary, and summary should be very, very, I will say, short in some sentences. So I think one, Dr. Supriya, you can do. Second, I will say, Dr. Yashwant, you can do. Put, I will say, summary in your own words. Supriya, can you do it? Would you like to make the attempt? Yes, please do it.
Yes, sir, I would like to try. Sir, on summary, the child is having subacute progressive dysfunction of the cerebral cortex, which is slowly progressive. The present functions are, sorry, I'm unable to comment on the present functions properly.
Okay, no problem. Fine. Yashwant, what will be your way? Always every person should have the unique way. And that is another thing which I wish from the students, that I think those who must be watching the Indian Idol, if you even listen the comments from the teachers, it is really that every person should be his own style. Try to develop your I will say, style. Second, it should be always impressive. And third, I like one comment of that, I will say, trainer, that whenever you are speaking, it should be, I will say, your own involvement. You are doing for yourself, not for others. Not, I will say, for teachers, for exam. You are doing for yourself. And once you have the involvement of yourself in the discussion, it is going to be the unique. So I think with that idea, Yashwant, what will be your way?
The illness is subacute in onset with predominantly gray matter involvement associated with white matter, and it is progressive in course with a history of measles and jaundice, and probable diagnosis were SSP autoimmune condition.
Right. Very good. I would say, always make very bold statements from your discussion. You can say that here, almost 12 years old boy has presented with the illness of total 1 month duration. and that is the subacute illness. Very nicely, both the, I will say, students mentioned. You can say from the presentation, it is very clear that there is the involvement of the nervous system. Very clearly, anybody can say that from the functions affected from the speech, memory, school performance, bladder bowel disturbances, it is very clear that it is a diffuse widespread cortical lesion. With the involvement of even the locomotion, I can say that it may be even the central involvement or even the peripheral spinal cord, but the white matter is also involved. So together, gray matter, white matter involvement is obvious. Very specifically, the optic nerve involvement and sudden loss of vision. Very commonly in this type of illness, we can suspect that maybe the optic atrophy. And you know that optic nerve involvement is highly suggesting the white matter involvement. Now with this anatomy, if I go in the details, it is a progressive disorder, not so slowly, but yes, it is a progressive disease. And in a 1 month period, it has resulted in such a condition that child is absolutely depending upon the others. So making the child, I will say, debilitating condition. Having this type of story, it is very obvious that it should be with the loss of achieved functions, it is some degenerative disorder. And degenerative disorders, very specifically the involvement of gray matter and white matter. Now regarding etiology, if I think, because the older child, probably the young presentations, degenerative disorders are in the, I will say, less possible or at the bottom of my possibilities. But then the acquired lesions are more likely. Acquired lesions can be, I will say, post-measles problem, can be HIV, can be nutritional. You know, you have to keep all these minds, I will say, differential diagram. Even the Wilson, yes, this is neurometabolic. So these are the various possibilities, but with the very history of the media, I may consider SSP as a strong possibility. So always come out. Somebody will say, Wilson, why? Yes, because but somehow it is not the basal ganglia involvements highly suggesting. School performance, yes, behavior problems can be there, some changing in the handwriting will be there, right? May not be the jaundice even, but this type of the Wilson presentation is known. So I think certainly if somebody is considering in the differential diagnosis, it is justified, it is considerable. So I think these are the things that how best we can do. And if you go for the multiple times these type of the presentations, discussions, then I'm sure that in the exam you will be very confident and your performance is going to be the good one. I think before we go further, any comment from some other teachers? Anything from Srinivasan sir, or I will say...
I have no comments. I already made my comments, so I want to keep quiet.
Yes, yes. Then I think Madam Suvarna or I think Dr. is also there in our Dr. Trupti, yes. Dr. Trupti, are you there? Do you want to say something? Madam Suvarna?
Nothing, sir. Like, I feel all the acquired causes can very well be described as differential diagnosis, as very well pointed by you. And then the other rare metabolic disorders may be part of this. But as the students know more of the acquired causes like SSP, Wilson, they'll be more confident in telling about them. So I think they can also guide the case towards that, maybe.
Absolutely. And then now, before we go for the examination, one more very important question. And please perform this type of the habit, not only the exam, in daily practice also. That having this type of the background of the information of the history, what you are expecting when you go to examine the patient. What you are expecting that these are the findings should be there, or you will check, is it there or not? So who will take that point? I think Karthik must have examined. So we will not go to Karthik because he must be knowing all the findings. But others, that what you are expecting in this patient, What will be, I will say, appearance of the child? What will be, I will say, posture or position of the child? What can be, I will say, vitals of the child? What other points you will check even the CNS examination? And what you are expecting in the child? That is very important. And it is said that as per my history, most of my findings should be there. And suppose by chance, according to my expectation, findings are different, go back to the history. That means something you have missed in the history. I will say to become a good clinician, always this should be your performance, not I will say only for the exam. So now coming to the question, I think one is Dr. Ansi. Yes, I hope that I am pronouncing it appropriately. Dr. Ansi, are you there?
Yes.
Yes. What you are expecting on the examination of this patient? Having this type of the history.
The CNS involved and upper motor neuron relation should be there. So I am expecting spasticity or hyperreflexia. I'm expecting, sir, on examination.
Okay.
The power will be reduced if the limbs are affected. If upper motor neuron is affected, the power may be reduced.
Right.
Then
Okay, so this is expectation from Dr. Anse. Supriya, what you are expecting, or what you will check even, whether it is there or not? Dr. Supriya?
Sir, we will examine the higher mental functions to check for the degree of loss of memory or attention span and speech that is affected, along with the motor system.
Supriya, do you expect the attention span in this patient? Do you expect? Or what will be your comment on expected, I would say, attention span?
Poor
So
attention span.
likely there will be the attention span will be reduced, or the child won't be able to cooperate enough for further examination.
I think when the child is having the problem of memory, forgetfulness, having the problem of, I will say, speech, having this problem of, I will say, multiple cortical disturbances, do you expect this attention span? I don't think so.
No.
Right?
No, sir.
Yeah.
Yes, sir.
Okay, anything further? Let's take it further. What will be other your findings?
Sir,
sir, gait abnormality will be there.
Yes,
Coordination will be affected.
and still, what will be the gait disturbance? Will the child be able to walk?
Sir, difficulty in walking. If we try to see the balance, maybe balance may be affected. Coordination may be affected.
What I mean to say that suppose with the support, if you support the child will be able to walk.
No, sir.
So even with, in spite of support, child is not able to walk.
Yes, sir. I have to check that.
Okay. And still, you are muted. Yes, yes, please take it further.
Sir, I have to check for dysrhodokinesia, knee heel test. I have to check if the patient
So
is able
that
to.
everything will. Do you expect that in this patient, this test will be positive?
If the cerebellum is affected, there is a chance
But
of.
do you expect the involvement of cerebellum in this patient?
Yes, sir.
Okay. So he's expecting that there may be some cerebral signs and he will check it. Okay. Then anything else? Anybody? Yashwant, would you like to make any comment? Anyway, I think what we are expecting, probably the child may not be in the good shape from the neurological higher functions point of view by this time. I'm not sure whether a child is able to recognize the parents. You can start from this. or even the surroundings. That we should check it, and may not be probably good orientation or even the time place person. May not be good, may not be totally absent, but may not be for 12 years old boy, which are expecting, may not be there. That number one. Second, I think vitals point of view, always you should check.
Vitals will be normal.
Vitals
Usually.
may be the stable. The only thing you should check the blood pressure. That is very important. Then on the contrary, what I'm expecting that there may be some even the, I would say, marks of injury, because the child is having the jerk, this type of the very specific jerks. And in that case, your already child had the fall and some head trauma. And therefore, what I'm expecting that this multiple, even many a time, the injury marks over the forehead, because that is very important. Unnoticed, he even the falls, he may be having the even, I will say, injury over the forehead. That is very common in this type of the patient. May not be at other places, but with this, I will say, type of the jerks, it is very common, myoclonic jerks. Further, even may not be the good nutrition, because in 1 month time, I'm not sure whether the child was able to take orally sufficiently the way which was taken before this illness. Further, on the CNS point of view, probably higher functions point of view, already we discussed, but the nerves optic is likely, and therefore for fundus examination is very important, which may even indicate the involvement of the optic atrophy or something optic nerve. Simultaneously, of course, we'll have to check for even the retina also, retina pigmentosa. You know that involvement is there. We can take a help of the expert ophthalmologist that may favor the involvement of the gray matter. In the gray matter, that is very classically retinal involvement, and optic involvement is very classically the white matter disorder, and that we can check. Motor system point of view, yes, maybe the spasticity initially, but later on may go for the hypotonia. This may be the probably stage of spasticity, maybe. DTR depends, initially maybe the brisk, but we are not sure whether it has reached to the diminished or absent. Plantar again can be the flexor or extensor, because that is the stage of not the total, it has gone to the white matter disorders. Bladder bowel, and therefore you can check whether the bladder is palpable. Many times it may be with the neurogenic bladder, or there may be the overflow. You should check for even the soiling the clothes. You should check even particularly the back spine, right? And I'm sure that even the cerebellum probably may not be the other findings. Skull may be normal, spine will be normal, gait probably may not be possible, and if at all, maybe with the support. So, these are our, I will say, presumption of the clinical findings according to our history. We have not seen the patient, we are not aware of the patient at all. Now, really, Karthik will give the picture that what is the status on examination. So, Karthik, I think now you can share your PPT and give us the account of the examination findings.
Yes, sir. On general examination,
Okay,
the child is
Karthik, make it full screen, please.
yes. On general examination, the child is awake, lying on the bed, and is conscious, oriented to time, place, and surrounding. Interacts with the mother. There's no pallor, icterus, cyanosis, edema, or any lymphadenopathy. Vitally, child has a temperature of 98.7 degrees Fahrenheit with a pulse rate of 80 per minute in the right radial artery with normal rhythm volume, and equally felt in all the four limbs. All the peripheral pulses are palpable with a respiratory rate of 20 per minute and saturation of 97 on room air, and a capillary refill time of less than 3 seconds with a blood pressure of 120 by 80 mm of Hg, which is between the 50th to 90th centile. Anthropometry, the child is weighing 32 kgs of expected 36.9 kgs, which is between median to -1 standard deviation. Has a height of 136 centimeters of expected 145.5 centimeters, which is between -1 to -2 standard deviation. Head circumference of 52 of expected 54, which is between median to plus one standard deviation, and a BMI of 17.3 of expected 18, which is between median to plus one standard deviation, where the growth and the child's growth is appropriate for the age. Head to toe examination. The head appears normal in shape. The hair is normal. There's no facial dysmorphism. Ears and eyes are normal. The oral cavity is normal. No chest deformity. He has a BCG scar present. The trunk is normal. Skin is normal with no hyper or hypopigmentation. There are no neurocutaneous markers. No external markers for TB and HIV. CNS examination. On higher mental functions, the child is conscious, alert, and cooperative. Behavioral wise, he has an abnormal laugh. He's oriented to time, place, and person. Attention span is normal. Uh, the remote memory is intact, but recent memory is affected. Intelligence is reduced. Speech, he has a slow, incoherent, reduced verbal output. These are the videos of the child. Here we can see the child having jerky movements. Uh, then we come to cranial nerve examination. In olfactory, the child can smell coffee in both the nostrils. Optic nerve, bilateral pupils are equal reactive to light. Color vision is normal. Distant vision is normal in the right eye, but decreased in the left eye. Field of vision is normal in the temporal and nasal fields. On fundus examination, macular dystrophy is present. Third, fourth, and sixth cranial nerve, pupillary reflexes are normal. There's no ptosis. Extraocular movements are normal. Trigeminal nerve, the boy can sense touch pain, temperature over bilateral phase. Able to chew food, bilateral corneal and conjunctival reflexes are present. Facial nerve, there's no facial asymmetry. Deviation of angle of mouth, can puff out cheek, able to close his eyes. Winkles are present on looking upwards, and taste sensation is present over the anterior two-thirds of the tongue. Vestibulocochlear nerve, hearing is intact. Rinne's test, air conduction is greater than bone conduction. And on Weber's test, vibration is heard equally on both the sides. Glossopharyngeal and vagus nerve, uvula is central and the child is able to swallow. There's no nasal regurgitation, no nasal twang. Gag reflex is present. Spinal accessory nerve, the child is able to turn his head on to the right and the left side. Hypoglossal nerve, there's no deviation of tongue and no atrophy or fasciculations of the tongue. Motor examination. The bulk of the child, there's no wasting and it is equal on both the sides on the right and left. Tone, the child has hypertonia in the lower limb. Power, the child is able to turn his neck to both the sides. In supine and prone position, the child is able to lift his head off the bed. Power in the shoulder, around the shoulder, all the muscles have a power of 5 by 5 on the right and left side. Muscles around the elbow, child has a power of 5 by 5 over right and left side. Then over the muscles around the hip, the child has a power of 5 by 5 on the right and the left side. And for muscles around the knee, the power is around 5 by 5 for on the right and left side. And muscles around the ankle, has the boy has a power of 5 by 5 over the right and left side. Reflexes, Superficial reflexes, corneal reflex is present on the right and left. Conjunctival reflex is present, abdominal reflex is present, pharyngeal reflex is present, plantar reflex is extensor on right and left, cremastic reflex is present. Then on deep tendon reflexes, biceps, the child has a grade of 3 plus on the right and left, triceps 3 plus, supinator 3 plus, knee jerk 3 plus, and ankle jerk of 3 plus. There are no release.
What is your interpretation of 3 plus?
3 plus is hyperreflexia, sir,
Okay,
suggesting
hyperreflexia.
any UMN lesion probably.
Okay, okay.
No release reflexes or no involuntary movements. Sensory system, the boy is able to perceive touch, pain, temperature difference, position and vibration sense in all the dermatomes. Cortical sensation is intact. Meningeal signs are absent. No signs of raised ICP. Cerebellar signs, the gait, child has myoclonic jerks while walking, giving rise to giveaway of limb and a tendency to fall. There's no nystagmus. Past pointing is present and the child is unable to do a finger nose test. There's no tenderness over the spine. Respiratory system, cardiovascular and parabdominal system are normal.
Okay, no organomegaly.
No organomegaly, sir.
Okay.
Fundus examination.
I think, can you stop sharing?
Yes.
Yeah.
So fundus examination.
Sir has mentioned fundus examination.
Macular dystrophy, sir. On fundus.
Yeah, he mentioned this.
Yes, sir.
Okay, can you stop sharing?
Yes.
Dr. Karthik, there was no any mark of injury?
No, sir, there was no mark.
Okay, fine. That means, it indicates the severity of these jerks. That means may not be that severe, which can cause the injury. Okay. Now, what do you mean by the external, some points regarding TB and HIV?
External markers. Maybe, sir, cervical lymphadenopathy.
Okay.
Or TB or any ulcer, any non-healing ulcer.
Right.
And
all these conditions can be in the differential diagnosis. It is not a very specific marker for TB or HIV. Right. So again, better to, I will say, remain away from. Suppose, as you mentioned, no neurocutaneous marker, that's good. Because they're very specific and they are the very specific for the neurocutaneous disorders. So that of the points you can take it. Anyway, I think anything is missed in his examination, in his presentation. Supriya, did you notice anything? On general, I would say when he has presented, anything is missed? Yashwant?
Yeah, he covered almost everything, sir.
But one thing is missed. Okay. And I think whatever the system it is, please don't miss in the examination. Signs of meningeal irritation he mentioned. That he mentioned. Yashwant, what did you say?
Meningeal irritation, yeah.
It is mentioned. Okay, B12 deficiency because of the markers, general examination, better to mention. The very important thing which I have missed is the growth chart. He has mentioned the anthropometry, but the growth chart on plotting, that always in the exam, please don't miss it.
Yes, sir.
Because whatever the system it is, at least we are expecting that every pediatrician should use the growth chart, not I will say just using, plot it and know the exact interpretation. So that should not be missed. Very good. I think I'm sure that Karthik, I would like to appreciate some videos which you have shown and some of the picture. I'm sure that Srinivasan sir will be happy. Every time Srinivasan sir points out that, here we don't see the patient online, this type of the discussion. On bedside, once the patient is there, I think we can see, we can even show the sign. But here, I think if you have some videos, some pictures, others can appreciate. And many times it is missed in the presentation, and Srinivasan sir always points out that better to take this type of the videos, this type of pictures. And certainly it is good. Nowadays it's very easy, I will say. Everybody can do it. So, and that you have done it. So let me even appreciate, because this is a good thing. Anyway, I think now who will summarize the positive findings of CNS examination? Only positive findings. And from that you can derive that where is the anatomy, which part of the nervous system is affected. Who will do? I want that voluntary somebody should come forward. That what he had described, now make the, I will say, summary of only positive findings. That will give the idea that what type of the problem the child has. Who will do? Please come forward by yourself, voluntarily. Because gradually as a teacher, I understand that I should not force somebody. They should come by their own. And if the voluntary participation, it is always good. I think Yashwant is there, Supriya is there, Dr. Nasir is there, some other students are also there. Anybody can, please. And he has, I will say, given the good finding. Who will do the summary? Yes, Yashwant? I hope that you are ready. Because you unmuted yourself, so I thought that you are ready. Please, come on. Come on, already he has given the finding. You can just put, I will say, positive points. Only positive point. You know why? Because that will give some picture in our mind.
Well, 11-year-old with
Suppose if we focus for the positive finding, Yashwant, number one, make any comment on higher function, normal or abnormal.
Speech was abnormal.
Yeah. At least you can say that higher functions are affected.
Abnormal.
Because memory is also affected, speech is affected, right? So higher functions are affected, number one. This is another thing which I want to guide the student, that then put the findings on your paper, even in exam also, which you can refer even while talking to the examiner or presenting. That will give the exact idea that on findings CNS you have seen that the higher functions are affected, number one. Second, what is your comment, Yashwant, for these cranial nerves?
Cranial nerve second was affected with the macular dystrophy.
So second nerve, is there any other nerve affected? No.
No.
So you can even write down on the paper that higher functions affected, only second nerve affected. Right. Now motor part? Motor part normal or abnormal?
Motor was normal.
Is it normal? He said that the hypertonia, he said hyperreflexia, plantar extension.
3+ reflex.
He mentioned, so what does it indicate? He mentioned hypertonia.
UMN lesion.
He mentioned hypertonia, no wasting, right? Coordination, he mentioned normal, no involuntary movements. And even this deep temporal reflexes, exaggerated plantar extension, reflexes also if we include. So very classically, it indicates the upper motor neuron type of lesion. Am I right? From the motor system examination, you can make the comment. Then sensory system normal, cerebral signs absent, signs of meningeal irritation absent, gait affected, right? Skull and spine apparently normal. So these are the positive findings. Now, what does it indicate, the positive findings? We can say the generalized diffuse cortical lesion, yes. Optic nerve is involved. And the upper motor neuron type of the lesion. right? So having this, and particularly myoclonic jerks, which I have described already. Now having these type of the findings, you can go for this, I will say, making the possibility, anatomy, then possible pathology, and then consider some common etiology. With this idea, Karthik, now you can go for your, I will say, summary which you have already mentioned. You can share your PPT.
Yes.
Let us see how you have done.
Uh, 11-year-old male boy born out of third-degree consanguineous marriage with previously normal development and scholastic performance, presented with subacute progressive neuroregression over 1 month, characterized by behavioral changes in the form of forgetfulness, incoherent speech, and reduced memory. This had progressed over 15 days to gait disturbance with inability to walk independently, difficulty in sitting, and loss of bowel and bladder control, along with progressive speech impairment. Over the last 3 days, he developed multiple myoclonic jerks during the awake state, and which was acute on onset, and sudden visual impairment in the left eye. On examination, the child was conscious oriented but with recent memory impairment and slow and irrelevant speech. Cranial examination was normal except for decreased vision in the left eye. Motor examination reveals normal bulk and power but increased tone in the lower limb with bilateral extensor plantar responses suggestive of UMN involvement. Anthropometry is appropriate for the age, and other systemic examination is normal.
Right. You have any further presentation? Okay, these are your possibilities.
Yes.
You will have to justify, right? At least keep in mind. Later on, we'll go for. Now, you have any further investigations, I think?
Yes, sir. We have done certain.
Okay, I think you can stop sharing. Investigations will take the last.
Yes.
Because, usually we are not much interested in the investigation. Investigations are usually for confirmation. And suppose if it is something else, you can plan for the further investigations. Now, Karthik, you mentioned the behavioral changes, and in the bracket you mentioned regarding speech, regarding memory. Are there really behavioral problems?
Suggesting cortical involvement, sir. Right.
No, because you mentioned, it's a different story. If you mention behavior, can you give some example of behavioral problems?
Like loss of memory, loss of memory, sir.
Loss of memory, the behavioral problem? It's not the behavioral problem. It's a cortical function. It's a high function. Yes, Srinivasan sir wants to say something. Sir.
He mentioned Wilson disease in the differential diagnosis, but he didn't mention anything about Wilson disease in the clinical examination.
Yeah.
And this thing, no, I think that is not acceptable.
I think initially you may keep it, but with this fine examination, probably it is not in the consideration. What sir said is absolutely right. On the contrary, if you mention the Wilson disease, somebody is going to ask
I mentioned this is it may give negative marking. And it's very important in DNB and all. Each and every mark should not be this thing.
Absolutely. Because somebody will ask you in this way, that which are the points from which you are keeping the possibility of Wilson disease. Can you justify? That's why, what I said, you have to justify all your possibilities.
Sir, one is age group, sir, around 5 to 15 years.
But your clinical findings are all totally not having anything.
Anyway,
any Wilson's ring, you didn't even tell about the cornea, whether any.
What you are expecting, suppose, forget regarding this patient. Very classical patient of the Wilson disease presented with the involvement of nervous system. What you are, I will say, and this is expected from you, that what you are getting clinical findings, or even in the case of neurological involvement of Wilson disease?
Sir, neuropsychiatric, it could include any.
One is a neuropsychiatric disorder. Okay, agree. Is there any neuropsychiatric problem in this patient?
Behavioral changes and. cognitive decline.
That's why I asked the question, what is behavioral problem? I will say memory, speech are not the behavioral problems. They are the
abnormal smiling.
Yes. So that you can mention.
Decreased
Abnormal, I will say laughing, even behaving to the parents, surrounding, even I will say not suppose beating somebody. These are or even throwing the objects. These are the behavioral problems, right? So usually classical Wilson is what you are expecting. Affected the school performance, yes. Later on, classically goes for, I will say, the involvement, the basal ganglia problems.
Movement disorders.
For the movement disorder is common. Maybe the flapping tremor or some type of the tremors, right?
Yes,
and later on, even if you go, there may be even the changing in the handwriting, deteriorating handwriting. There may be the very classical. Even if you examine, very much chances in 12 years old boy with the Wilson that you may get some carefree, right, laser fluxative that you may get even the on the corneal examination, and even you may get the hepatomegaly, may not be on the patient, but maybe occasionally even maybe the jaundice or something. Or so I think what you are expecting in a classical neurological manifestation of Wilson, in this patient, at least we cannot justify. And that is the reason that better not to mention. Initially in the history part, okay. I think after this examination, you are very clear. Okay, what was your second possibility? Other your possibility? Leukodystrophy. Okay, what is the leukodystrophy?
So as there is some movement disorder.
Okay.
And
again your leukodystrophy, they are involving the white matter.
White matter.
Right. And usually therefore they start with the locomotion. Later on, progress of the disease may involve the gray matter also, right, with the progress of the disease. And therefore, even suppose if you are considering the possibility, it is not totally wrong, right? Okay.
Yes.
What are the further possibility?
Demyelinating.
Sorry?
Acute demyelinating disorder.
Okay. Again, probably the story may be different, but in differential diagnosis, somebody is keeping it is not totally wrong. Anyway, how you are keeping the SSP in this patient?
As there is a positive history of measles, so that would be. And usually
always Karthik, start from, I will say, once you are justifying your possibility, again, collect the points from the history, collect the points from the examination, particularly suggesting that particular condition, and then you can justify and always start from the history. Suppose here you can start from the age of the patient, whether the age is favoring for SSP.
The age of present, yes, sir, because usually it is around after 6 to 8 years post-infection.
So, always you can start in this way, that yes, age is suggesting.
Age is suggesting.
This age, SSP is possible. What I mean to say, usually the older children it presents after a few years of either the measles disease or measles vaccination. And usually 5 to 7 years beyond that, commonly we get it. So always find out the points. Number one. What are the other points?
Behavioral changes, sir.
You can say it's a subacute condition.
Yes.
Right. Usually subacute to chronic condition. If you must be knowing there are the different stages of SSP.
Yes.
Right. What are the stages? Initially,
just
start with So can you just describe it for, I will say, other students also?
Stage 1 is early stage, sir. It usually presents with behavioral changes, decreased school performance, and affecting memory, sir.
Absolutely. I think here in the beginning of the stage, even somebody goes to the medical person, doctor, then also may not be able to consider the SSP because they are the very vague symptoms. But first time probably you may get this type of note from the school that his performance is deteriorating.
Yes.
He is having some behavioral problems. He was not behaving in this way in the classroom. That may be the note from the teacher. I think that will be very easily overlooked by the parents and even sometimes the medical person. Right. Okay. What happens in the second stage?
In the second stage, usually we get motor dysfunctions are in the form of
Yes.
myoclonic jerks can be present.
Sometimes then again you will observe that he has some abnormal movements, may not be very classical jerks. Another point which already you mentioned, and even it was there in your history, that frequent falls.
Frequent
His gait
falls.
is changed. He's not able to maintain the balance. So
Yes.
frequent falls, injury over the forehead, or sometimes as already in your patient, there was even the injury over the head. This time the story is common. And I think now if some clinician is going on the details on follow-up, that started with these school problems, behavior problems, and now even these some jerky movements and even these type of the gait problems. Meanwhile, if you have observed that this is a really classical story. I remember one of my patients, which was referred to me with non-specific symptoms. But when I was taking the history, I was asking the mother, child was there, 7, 8 years old girl. Suddenly she had struck, I will say, her head to my table. That was the myoclonic jerks. That was a very classical, I will say, point suggesting SSP. I remember that from that girl, from the very beginning, very classical presentation, I suspected and later on proved to be the SSP. So that type of the points I will say the clinician will have to try to locate. Right. Further, I think if you can go, that yes, the myoclonic jerks deteriorating, then even this locomotion is affected, may not be able to walk even with support also gradually with, right? Gradual loss of the higher function, deterioration is quite possible. May not be even the controllable myoclonic jerks, right? So I think in this patient, you can say that it is justified. Now, if you say with the spasticity and DTR, what stage has come?
Stage 3, sir.
Yeah, and then what happens in stage 4?
Stage 4, like the vision.
Stage 4, even the orientation of memory and everything is lost. Right? Behavioral problems increase. Child may not be able to walk even with the support. Now, probably rather than the spasticity, there may be the hypotonia, or maybe the deep tendon reflexes diminish. These levels, and then gradually patient go for further deterioration. So that is very classical story, as it happens in any chronic disease like tuberculosis. That type of story stages are there in a case of SSP. And I think in this patient, if you try to correlate, that may favor the possibility. Okay, I think you have mentioned regarding this history of measles, how the measles helps you? How will you correlate that history of measles?
Like SSP as a complication of measles, sir.
Okay. So suppose now, before you go for this, I will say the investigations, presentation for what you will plan the investigation. I will say, let me go to the other students. You must have prepared. Yashwant, now I think clinically we have thought of this SSP. Number one, neurologically, how this disorder is classified. Supriya? Yashwant, anybody? Neurologically, how this disease is classified? Karthik?
As a white matter disease, sir.
Generally, what we say from the function point of view, yes.
Subacute chronic cortical involvement.
You know, it's a degenerative disorder.
Degenerative.
Is there any other, I will say, way of classifying this disease? What happens after the history of measles and it results in SSP? What happens to that virus? You know, many people classify the slow viral infections. There are certain viruses, they remain in the body, particularly neurologically, and slowly progress and results in the manifestations after years together of the entry in the body. So many times, like rabies also. So it is classified in even this either the neurodegenerative disorder or slow viral encephalitis, like classification is there. Anyway, what investigations you will plan?
So we would start with an EEG.
Okay, what you are expecting EEG? You know,
Sir,
in the, again, I think those who are in the DNB, probably in MD examination also, many universities they take the OSCE. And the OSCE, these are the questions are going to be there. They will put some very specific EEG finding, and they say, what is your EEG interpretation? And then what does it suggest? Because SSP is having the very specific EEG changes. What changes, Karthik, you are going to get it?
slow wave complexes, sir.
Right?
And
What
periodically there are like voltages with corresponding with the jerks.
Yes.
Myoclonic jerk.
Very good. What further investigation?
Then I would plan for lumbar puncture, sir, to have a
Yes.
CSF study, sir.
CSF, what will you do?
And CSF measles antibody titers.
Measles
IgG.
antibody titer, yes. Whether it is possible at your place?
Yes, sir.
Yeah.
It is possible.
Should it be done in CSF or blood?
Serum total IgG also can be done.
So in the serum also it can be.
Serum also
but
can
more reliable is the CSF,
CSF.
measles antibody titer. Okay.
Yes.
Anything else?
MRI brain. Sir.
MRI brain can be
to
there.
see
What you will get in MRI brain?
early cortical involvement or any demyelination.
Okay.
Demyelination, sir. Demyelination.
Right. I think now, because we have reached to the time, you can share your PPT, whatever the investigations you have performed. And then
demyelinating only brain is important, or also spinal cord?
Spinal cord also, yes.
Spinal cord also. Spinal.
Yes, Karthik. Go to the investigation and make it full screen.
Yes. Sir, the boy had a hemoglobin of 12.8, sir. TLC of 9,900, platelets of 2,59,000.
I think Karthik, I will suggest to postgraduate, rather than reading the figures, you can say that CBC was within normal limits.
Within normal limits, yes.
Yeah, that should be a good comment. Okay, yes. Please go ahead.
CBC was within normal limits, sir. LFT, liver function test was within normal limits. The renal function test was within normal limits.
Fine. What is your idea to go for ammonia?
To see any neuronal involvement.
Do you expect in this patient? You know, nowadays we say that go investigations also rationally.
Yes.
Anyway, no problem.
Then
thyroid function normal.
Thyroid is normal, sir. Serum lactate of 5.1, which is on the higher side. USG, abdomen and pelvis to look for organomegaly.
Do you expect in this patient?
No. There was no organomegaly clinically, sir.
Yeah. Okay.
Then on the CSF study, CSF was normal. CSF culture was sterile and ADA was less than 1.
Have you gone for the gene expert in this patient, CSF?
No, sir.
Is it justified? Suppose somebody is asking.
Gene expert.
Is it justified?
Yes.
Yes, we should. Reason is, tuberculosis presentation have been different, even I will say, in our country. We have the very wide experience. I remember the very classical findings of only Korea turn out to be the tuberculosis. Only Korea.
Okay.
So it's not the uncommon story. Very classical picture for SSP, but by chance if you get even the tuberculosis, it's not surprise to me. Possible.
Yes, sir.
Less likely, I will say, least possible even, but occasionally, suppose if you come across, it will not be a surprise to me that yes, tuberculosis can present in this way. Okay.
Then on MRI, sir, there were hyperintensities in bilateral periventricular region along the anterior aspect. EEG showed abnormal slow background along with generalized epileptiform discharges, sir. Then on additional investigations, we had done ACTH, which was less than 1.5 with a normal value of 7.2 to 63.6. Serum IgG measles was 206, sir, and total IgG serum was 1452, which was within the normal limit. But CSF IgG measles was raised, and total CSF total IgG was raised, sir,
Right.
suggesting
Okay.
measles.
Anything else?
No, sir.
Okay. Can you stop sharing now? Because already
Yes.
we have reached to the time. Fine. I think before we go to end the discussion, anybody's comment, anything? I think before we wind up, yes, Dr. Suvarna Madam. First,
Yes, sir.
yes, please.
Sir, it was very enlightening and enriching experience for me also to learn how to go ahead and get maximum things from students. So I really enjoyed the entire 2 hours. And I would just like to add this, these are the very well common differentials discussed, and that's how they should know all of this. Only thing is, if there is organomegaly, additionally like hepatosplenomegaly, lysosomal storage disorders can be considered, like Niemann-Pick type, Niemann-Pick disease, mucopolysaccharidosis, Gaucher disease, etc. can also be considered. So
I think
here
Karthik, yes, madam, please you complete. Sorry.
Yeah, no. So here it was not there. So it's
Yeah.
predominant without organomegaly and with organomegaly. That is how the Nelson has classified.
Right.
So we had the entire approach without organomegaly. It was
Yes.
wonderful.
I understand. I think that for that reason, some investigations were performed and it is justified. Karthik, in the exam point of view, somebody is going to ask you, what do you mean by the degenerative disorder?
Myelin.
Very simple. What you mean by it?
Like there's degeneration of the myelin.
There is a regression of the milestone, very classically. When you will suspect
gradual
that already the child achieved those milestones,
and
gradually the due course of time, child is losing. That is very classical. Here, why I ask the question, somebody is going to ask, how will you differentiate delayed development and the regression of milestone? How will you differentiate? What is the difference in the delayed development and regression? Regression will already be discussed. That there is loss of the achieved milestone. What do you mean by the delayed development?
Delayed development, sir, the attainment of milestones only is delayed. But in neuroregression, he has already attained the milestones, but then he tends to lose it and go back.
Delayed how much? Many parents will come to you that 15 months, even the 1-year-old child, that child is not walking. Is it delayed? Or my child is not able to speak even the sentences at 1 year or even the 18 months. Is it delayed? And it happens, I will say, in our daily practice, parents will come, because now I will say in some other sibling or relative children, they are speaking, they are doing. So that is very important. Number one, always please keep certain principles of development in mind. The development is having the very wide variation. And that first you should decide. For that age, for that milestone, if less than standard 2 deviation, then you can define. I will say 2-3 terminology is very important from the exam point of view, which people are going to ask you. Once you say delayed, what is the dissociation in the delayed development and what is the deviation in the delayed development? What do you mean by it? Any idea? Anybody?
Like dissociation is not getting the proper, it more than one domain is affected.
That is the global delayed development. Then the next question will be, you are guiding me that what should be the next question. I would say good candidate. Delayed development, you can say when it will be the isolated and global. More than 2, I will say, domains are affected. We say it is a global delayed development. Now in this global delayed development, all the domains may not be equally affected. Some are more affected, some are less affected all, but more or less, they are not, I will say, equal. Then we say that a dissociation.
Dissociation.
I will give you the one more question. So can you give the example where the motor milestone is more affected? Speech and social is normal. And otherwise child is normal. Later on after the treatment even comes to normal. Can you give us an example where motor is affected? Fine motor may be less affected, but more personal and social. And later on after the treatment, everything comes to normal. Suppose I will say, very common in your pediatric practice, this is not uncommon. Mother will say that my child is not able to sit or walk even according to the age, but he is able to understand, even the play, recognize the parents, playing with other children, even speaks also. After certain treatment, because you found that the nutrition was the problem. After correction of the nutrition, motor milestone, or even some illness. So it's a dissociation. One more example, where motor part is normal, absolutely normal. Just language and personal social is affected. Which disorder will be present in this way?
Motor is normal and
Motor part is absolutely normal. Speaking, even the sitting, walking, running, everything is normal. Even writing according to the age, but somehow not speaking much, not responding much, not playing with other children. Hearing is normal. Dr. Taruna, I appreciate. Yes, hearing is normal. Autism. You know, autism presents in this way. That is the dissociation. Right? And one more terminology, the deviation. What is the deviation? You know, motor milestone, all the developmental milestones have the variation, but the sequence is same. First child should be the head control, then sitting, then walking. It cannot be first, I will say, walking and then sitting. That is the deviation. End preference at 1 year is too early. And that indicates the deviation of the sequence. And that indicates some neurological problem, most commonly with the cerebral palsy. So that I will say very common for any general pediatrician, which we should know: normal development, delayed, deviation, dissociation, regression, and even one more is the pseudo regression. The pseudo regression is due to, suppose in a case of cerebral palsy, even the uncontrolled epilepsy, but once you control, child becomes better. There is pseudo regression. Or due to some illness, there may be the pseudo regression. With the B12 deficiency, pseudo regression. If you treat it, child becomes normal. Or even in a CP contracture, but with the physiotherapy, child improves. So all these are the examples of pseudo regression. Anyway, I think this is very common in our exam point of view, and just from your discussion, it reminded me. But already you are overshooted the time. We'll have to end over here. Karthik, first, really, I will appreciate you. You have done the very good job.
Thank you, sir.
Number one, selection of the case, good. Second, even you have presented very nicely with your history and all the points. Even your videos and pictures, quite appreciable. And I'm sure that it increases your confidence. And go for the multiple times presentation. Never say no. Whatever you should say that I will do. I will present. Next Tuesday, I will be there. Third Tuesday, I will be there. I think you should not give the opportunity to somebody else. Like that, the students will be ready. And then I'm sure that the exam, you don't have any hesitation. On the contrary, you can impress the examiner. And certainly I understand that your mentor must have taken the lots of, I will say, efforts, pains to prepare all the things. Yes. And Dr. Suvarna Madam, Magar, naturally, she deserves the best compliments for this selection, everything, I will say, learning not only for the students, but for all of us. And of course, the whole show is managed by Dr. Nehal, Dr. Trupti Madam, Arif, even so many other friends are taking the pains and therefore we are able to enjoy the learning for 2 hours. And of course, ultimately the whole credit goes to our central IIP. Our president, very dynamic lady, Dr. Nilam Madam, Dr. Ruchira, that they are providing this platform to us, to all of us. And certainly I will appreciate that all these officers there, just I will say they, to give this opportunity to so many students and even the teachers like all of us. It's a great opportunity for learning. And certainly for that, credit goes to the office bearer of Central IIP. And we can learn that even at this age, Dr. Srinivasan sir is not missing to learn, to listen to all of us. Please, I will say, remember this thing. Or I think that is for us. That sometimes now with this age, people are reluctant to learn. उसमें क्या पढ़ने का है, देखा है, नया क्या होगा? Right, we are always making these comments. But he is still, I will say, learning, and that is a great, I will say, inspiration for all of us. With these points, I will end over here, and over to even I think Nihal or Arif or somebody, those who are able to take.
Yes, sir, I am there.
Thank you very much. Okay.
Thank you, sir. Thank you so much. It was really an excellent conduct of PG activity. Even we learned from you, sir. And definitely Srinivasan, sir. So we should learn that we are students for the whole life. Yes, forever. Yes, sir. So we have to keep on learning. And each case, there is something new to learn. So each case teaches us a lot of things. Thank you so much, sir.
Thank you, Alamat, everybody. And
all
we
of
end
you.
over here.
Thank you.
And good night. And next Tuesday again at 6 o'clock. Please, I think, wait for the 6 o'clock Tuesday.
Thank you, sir.
There will be some new case, good discussion, participation of the students. And I think all of us should be very dynamic. Thank you very much with this remark.
Thank you so much, sir.
Thank you so much.
Thank you and good night to all of you. Thank you.